Hello, everyone. I hope everyone is doing fine. It's a pleasure to welcome you once again for our clinical case discussion symposium that we organize with the International Race Centers. I would like to thank all the panelists for joining and for helping for the debate. I would like to remind you that is an interactive symposium, so please, for all the attendees, feel free to ask any question and to join the discussion. Today, Lucian Marcovici will be moderating the chat. And we have 3 cases and 1 video that were prepared by our fellows. So we will start right now with the first case by Francesca Teodonno. Hello, Francesca.
Hello, everybody.
Francesca used to be our fellow here in Paris, and now she came back to her hospital in Madrid, and she will be presenting a very interesting case of distal radius malunion and DRUJ issues. So, Francesca, if you are ready, please.
Okay, so does everybody see my screen?
It is perfect. Thank you.
Okay,
well, you can start, and please stop sometimes to ask our panelists for their opinion. Thank you, Francesca.
For sure. Thank you, Alam, for inviting me. I'm going to present you this case from Madrid. So it's a 62-year-old woman. It's a non-dominant hand, non-heavy worker. In 2012, she sustains a distal radius fracture. She consults in our center 4 years after for loss of strength, ulnar pain, and in exploration, she had a big DRUJ instability and radial deviation. So the person that saw her at the time did not ask for any MRI or any CT scan and decided to treat her. So I would like to ask one of the participants, what would they do with this case? These are the only images that we have. The surgeon at the time decided to address the radius malunion, doing a radius osteotomy, and decided to address the DRUJ problem with the ulnar shortening osteotomy. Does somebody would like to make a short comment on this operation?
Anyone,
what do you
please,
think?
from the panelists?
I'm concerned about the hi, Logan.
Hello, Logan.
I'm concerned about the DRUJ. It's quite wide here, the alignment, and in terms of doing an ulnar shortening osteotomy, it doesn't actually look like enough of a shortening has been done because it is still quite ulnar positive.
I completely agree with this comment. I think the major problem at this point is that the radial height is not restored. Supposedly in the notes, the surgeon used the graft, but me personally seeing the x-rays, I see no graft. And I think this is the problem, that the ulnar shortening, it is insufficient to address the DRUJ problem because of the radial height. So clearly this is announced disasters.
I have just, if you can stop and go back, Francesca, because it's very interesting here. I think the question we should ask now, was the ulnar shortening an indication here for years after the first trauma? You can see, hello, René. Could you help us in this? How are you doing?
Hello, Alam.
Sorry
for the vieja. Fine, and you?
It's a very fine, thank you. You said you know it is a very interesting. And just in the beginning, could you share your opinion about this first indication of ulnar shortening osteotomy, because it's really interesting for the first decision that was made.
Yes. Hi, everybody. I think that is the malunion on the distal radius and after the fracture. And I think that is the first option in the patient. The patient has a pain. The osteotomy on the radius is the first time on the surgery. I think that is the very good option. The second, I need to evaluate what is the the state of the TFCC and the distal radius tissue stabilization, pronator, TFCC, DOB, and another anatomical very important. And in the third step, the ulnar shortening is important when I have a big impaction syndrome on the ulnar side. I think that in this moment, I don't know what is the symptoms of the patients in the distal radial ulnar joint. Continue of the pain in the ulnar side and instability.
Francesca didn't see the patients in the first place.
Yeah. What the symptoms?
Francesca, what were the? Yes.
I can say that after the surgery, the ulnar pain did not disappear. And if you want, I can keep on going with the.
We have a good answer. I would like to comment also from Bülent Özelik from Istanbul.
In the first step, we saw ulnar styloid fracture. That means that it's instability in the distal radial ulnar joint. And in the first step, we have to do radial opening wedge osteotomy, not closing wedge, or we haven't got any possibility to excise the radius. And they correct now in the second slide, we saw that the inclination of the radius corrected, but we have a problem in the ulnar side. It's still continue, and the shortening osteotomy is not work. And we have two options in this case now. I think the first options, if you have a distal radial ulnar joint prosthesis, shaker prosthesis is work well in this position. In the second options is Sauer-Kappanji, I think. It is it's much more beneficial for this patient.
Do you think we can perform Sauer-Kappanji here at this stage now? Okay.
Yes. It is, and second, the first option, if it's available in our country, it is not available now. The shaker prosthesis is work well in this kind of position, I think.
Okay, I have just thank you, Dr. Özelik. I need there is Gustavo Gomez and after René Forquera that wanted to make a comment, please. Gustavo.
Hi, Alam. Hi, everybody.
Hi, Gustavo. How are you doing?
Well, I think that in the beginning, the main problem was, of course, it was very clear that the problem was in the radius because we have lost the radial inclination, the volar tilt, and we have a very positive ulnar variance. So I think that we should always approach the distal radius because the problem is on the distal radius, and the distal radius osteotomy seems to be the solution. But we need, because of the ulnar variance, we need to increase the height of the radius to decrease, of course, the ulnar variance. So perhaps it's you don't have to touch the ulna. The problem here is perhaps that the woman is a smoker, so perhaps the surgeon don't want to do a wide opening osteotomy of the distal radius. So it was the reason because he chose to do a shortening osteotomy of the ulna. The problem is that we still have a distal radial ulnar joint instability, so because it's very wide, the joint. So I think it's very important to check the TFCC to give stability, not only to make the osteotomy of the radius and the osteotomy of the ulna, but also to give stability to the distal radial ulnar joint.
Just because the patient was smokers, he did a simple osteotomy of the radius. That is your opinion, Gustavo? Because most of the time, but just doing the correct osteotomy on the radius is sufficient.
Exactly.
It's enough. Yes, yeah. It's enough. Just after we can just add a wafer or something like that. But here it's
yes, but that is just what I think he thought before operate the patient, but I don't know if it was the main reason.
The case, sorry, everyone. Thank you, Gustavo. The case is very long, so Francesca, could you move? Yes.
Gustavo Mantovani asks if we have some elbow images.
I think no, because it is a very old case. So Francesca came just after. I think she doesn't have the elbow X-rays. Francesca?
No, I have no elbow images, but like she has no problem at the elbow. Like there is, this all starts with the distal radius fracture malunion. There is no traumatism at the elbow of the level. So yes, I think also that the radial height is not really, it has not been addressed completely. So the woman keeps having ulnar pain. This is her evolution towards the years. For the moment, she doesn't have to want any more surgeries, but then she does sustains a fall. Her instability gets worse. And this is the first time I see her with these X-rays. At this point in 2021, she has loss of strength, she has ulnar pain, and she also has median nerve compression. At this point, I do ask for an MRI and a CT scan. The MRI was completely useless because of all the metal of the plates and the screws, but the CT scan showed us that she had no radiocarpal osteoarthritis, no midcarpal osteoarthritis. The ulna was consolidated, and there was a doubt whether the radius was consolidated or not. This is the external aspect of the wrist. And this, I think, is the three problems that now we need to address at this moment. So if somebody wants to comment on this.
Thank you. Very difficult. I think René was wanted to talk.
In this moment, change my opinion. When I see of the new image and the previous image, I think the one opinion the bone procedures is very good on the osteotomy and the ulnar shortening, and I can see of the open of the distal radial joint, and I think that is the very big instability and produce of the pain in the ulnar side. It is my opinion in the first. Currently, I see the disaster of the ancilotrosis and deviation. It's very difficult. The decision of the way is the new and another procedure of the treatment in the patients. Yushan, solve me, please.
So
I think that we are back to the start now with another problem, which is a plate. But if we see the previous X-rays, we see that the plate was not positioned in a correct way. It was distanced from the bone, and the screws. Maybe they didn't put them in a correct way. So she probably went to a non-union from the first osteotomy, which became symptomatic after the fall. But for me, we should revise osteotomy. I will take the risk.
Revise radius osteotomy.
Yeah.
Yes. And what about
the first problem is the radius, like Gustavo said, and I will try to do it better.
I think we are. Don't forget that we are 4 years after the first surgery. So don't you think we should do something on the ulna and address the DRUJ now? Someone would like to make a comment. I can see. Oops. Gustavo Montovani, I can see you here. Maybe you could help us, Gustavo. Hello. We can't really hear you, Gustavo.
Okay, can you hear me?
Yes. Hello, Gustavo. How are you doing?
Yeah, very fine. Sorry, I get late a little bit, so I lost some minutes of the presentation. But I guess with this terrible situation, it's not a big problem what I missed. But I was writing about the elbow first because I do not know if there was or not another problem. And I would like to make a comment on the situation before. Before we started to discuss about the soft tissues, reconstructions, and instabilities, I think is paramount to understand the bone deformity. So I believe in that first trial to correction, there was some mistakes and some residual deformities that was not addressed. So in my opinion, was very interesting and very important if we could analyze properly, three-dimensionally, the deformity. I think there was also a miscorrection in the distal part of the radius, in the curvature, and in the medial translation of the distal fragment. So that's it's an important factor to increase the problem in the DRUJ instability. So I would go for a more anatomical correction of the bone first at all, before thinking about the deformities at the first step. At this situation right now, I think we also need to think about the correction of the bone deformity first of all, because otherwise any try to salvage procedure, even the salvage procedures like prostheses or like the interpositions or like the cervical are doomed to have a bad prognosis. So I would go for a proper evaluation of the 3D deformity and try to have a 3D planning for the correction of the radius. And in the case of the DRUJ, now in this situation, I think it's probably not more able to save this DRUJ. Probably the cartilage is already damaged or not okay. But you can check it, of course, in the intraoperative onset. And if the cartilage is okay, I think a good way to stabilize this situation is our proposal for the reconstruction of the distal part of the interosseous membrane. So the technique using the brachyradialis is a very interesting option. Even if you do another osteotomy in this case, you can have enough space from the radius in the distal part of the radius to have this kind of reconstruction if the cartilage is okay. If the cartilage is not okay, there is a variation of our technique for arthritic DRUJ that we have just created, in which we interpose the tendon graft, but it's a technique we will still gonna publish. But I will go for, first of all, for trying to reconstruct the bone deformity, the radius deformity in the 3D planet model, and then choose the right option for the DRUJ salvage procedure.
So in two surgeries. So first, you don't take the decision for the DRUJ during the first surgery. You do the first surgery on the radius. You check how it evaluates, and after you decide for the DRUJ in this case.
Yeah, since it's going to be a big surgery, you can propose it in 2 steps. It's possible to make in one single step, but I think it should be more affordable to propose 2 steps surgery to address bone deformity. First of all, see how it evolution the DRUJ, check how this instability looks like. Eventually, I had some cases of big forearm deformities in which I did not have to make any kind of DRUJ procedure after all. Just reconstructing the proper anatomy, and that the interosseous membrane plays a role in this, you can even restore a good DRUJ function. So it's interesting to split into separate steps.
Thank you so much, Gustavo. Francesca, can we conclude the case, please, and see what you choose?
Yeah, so I operated this case with my colleague Javier Cervera. We operated this in Fundación Jiménez Díaz. So we try to keep things simple. So what we did was we first removed the old radius plate. We did see that the radius was in complete pseudoarthrosis. So we did ask for a iliac crest from the bone bank. We did a cortical graft. We did take some bone marrow from the iliac crest of the patient. And then for the DRUJ, we did a direct technique. Overall, I think we did restore radial height. And I think, I'm sorry I don't have better x-rays at this, but I can show you the next slide. So I think one of the mistakes was that we didn't fix with a screw the cortical graft, so the cortical graft moved. So overall, the patient had a good evolution with this surgery. You can see that the graft is reabsorbing, and she did had an unstable stump, but clinically it was not very important. And I saw her 4 days ago. These are her last X-rays. You can see that the graft is basically reabsorbing, and the ulnar stump is less unstable. And I think most importantly overall is that the patient is happy because she doesn't have the ulnar pain anymore, and she did gain strength. She actually says that she has more strength on the left hand now than the right hand. These are some videos to show you how she moves. So she has a very good range of movement. And there is still a ballotment test that is still positive, but again, I think clinically is not relevant. So to conclude a bit this case, what I've learned from this case is that as we discussed radial height, it is very important. I think if we managed to restore radial height and we did the TENS, the distal oblique band, and we did not have to do any type of reconstruction or anything. And then we did think of doing a foveal procedure, but literally we did not have any place to put the screw in the radius to do a foveal. So we did do a direct. And overall, I think a direct is a safe procedure, is an easy procedure, reliable. You do have a certain instability afterwards, but we are now 2 years post-op, and the patient, she does have instability that is overall less and less, and it's not clinically important.
Thank you, Francesca, for this nice case. I think now the question we wonder is what will happen after, if because the clinical situation is good now after 2 years. And if the situation even worsen after, what should we do? Should we go, I would like to ask the panelists' opinion, should we go for a shaker prosthesis now or interposition arthroplasty? We had this kind of discussion this morning on the wall group. Does anyone have an opinion about this?
I would like to ask a question to Francesca. Yes. Francesca, can you hear me?
Yes.
Are you not concerned about this apparent non-union in the radius?
Yes, but I also we also have experience that every time we use a bone bank graft, it reabsorbs. And I think that since the screws are well placed in the radius on the distal side and on the proximal side, in reality, this graft that we put, it almost acts like a spacer. So as long as nothing collapses, as long as she doesn't, like, of course, she can have a big fall and everything gets destroyed to pieces again. But for the moment, we have seen these reabsorptions of grafts, and as long as clinically there is no problem, of course, this woman, she doesn't want to have any more surgeries, and overall she's satisfied because right now her wrist is straight and she doesn't have pain anymore. And I think this is a very important thing.
Budant would like to make a comment.
I think that in the first step, you could use the ulnar stump which you remove in the, for the bone gap. It's possible. And now it's not easy to put shaker prosthesis in this kind of after this kind of screws. It's not possible to put shaker prosthesis, but and the other comment for the first step, I have got a lot of Sao Kapanji operations, and I think that Sao Kapanji is good options for distal radioulnar instability, which you have arthritis in the distal radioulnar joint. And in the first step, or in the second step, I choose the Sao Kapanji, and I can use the excision, ulnar excision part to get union in the radius. And now you have to repeat the non-union treatment. I think you have to repeat non-union treatment.
Thank you. We have Lucian and Gustavo Gomez.
First, Gustavo.
Gustavo.
Okay, thank you. Well, I want to say that I would have done the same than Francesca. I'm very agree with the solution of the case. I trust in the DRUJ procedure because it's a very simple procedure with no complications. The problem we have here with the Sove-Kapanji procedure and the shaker prosthesis is that we have to have a good radius, because the shaker prosthesis has a fixation on the radius, and the Sove-Kapanji too. You have to fix the ulnar head to the radius. So it's very difficult to imagine to do this when you have a non-union on the radius. But I'm a little bit concerned about the non-union side. So my advice for Francesca, because I had a very similar case, is that you have or you should control this patient. Don't tell to the patient, okay, you are healed, you can do whatever you want. You have to check the patient non-union side with CT scan during the time, you have to check if you are having the close of the gap between the epiphysis and the metaphysis of the radius, because if not, my advice, before have a new catastrophe, you can perform a dorsal approach and you can impact graft, cancellous graft, like for example a masquelette. Okay, you can remove the fibrosous tissues. You can put a little bit of cancellous graft, so you can increase the probability to the heal of the radius.
Thank you, Gustavo. So the main concern indeed is this non-union in the radius, even if the patient is asymptomatic. Thank you, Gustavo. I will take one comment, and after we need to move to the next case, please. I have Lucian, maybe Abdelrahman. Hello. Lucian. We don't hear you.
I agree with everything that Gustavo said. I want to ask Francesca if she thought to stabilize the ulnar stump with tendon slip, like the extensor ulnaris carpis or something like this. During the operation, I do it quite a lot in dark when I do a dark procedure, because it gives me a better feeling about stability, and it's like 1 minute more for the operation.
I did think about it during the surgery, but then intraoperatively we saw that it was sufficiently stable to not add more surgical time, because in the end it was a very long surgery, because we had to get the iliac crest to shape it as the radius, and like the radial part was actually quite long. And overall, she is a smoker. Right now, she's 73. So I was also concerned about infections. So I didn't want to make it longer. And then the literature in the end says that yes, there is an instability of the stump, but it's not clinically relevant. I thought in a second, like if it would have been an unstable, painful stump, I could have done like a Jupiter procedure with half of the strand of FCU and ECU to do bone tunnels. But for the moment, this is not a problem. I think what Gustavo said is important, that the main problem is the non-union. Clearly, the patient, she's 73, she's a smoker. She, like, biologically, it's complicated. And I think I will follow his advice to revise her, and worst case scenario, do what he said, like a dorsal approach, and do that.
Thank you so much, Francesca. We have final advice. Lucian, you can see on the chat a final advice form, I can see.
Yes, Gustavo Mantovani gives us final advice that this is a clock bomb, as Gustavo Dom said. I would not be happy with the actual result, and not free patient. Try something for the non-union. But Francesca already told us that she will do it.
So we all agree for this. Abhijit says Samba. And hello, Abhijit. So thank you so much, Francesca. Maybe we can keep us posted for your patient in the future symposium. So
thank you, everybody.
Thank you, Francesca. You stay with us. And now for the next, you can stop to share your screen. For the next case, we have Sao Paulo. Now, Robin Villegas. I hope I pronounce it correctly. Hello, Robin.
It's correct.
Robin is
hello, good everyone.
Hello, Robin is a fellow of IWC Sao Paulo with Gustavo Mantovani. They have a very nice case and a surgical technique for management of severe carpal instability. And I let you share your screen, Robin, please.
In Sao Paulo, Brazil. Your presence and interest in this medical case presentation hold immense value for our team. I would also like to extend my appreciation to the international risk centers for their generous support and for providing us the opportunity to share this case with all of you. Um, so, our patient is a 35 years old male who works as an orthopedic surgeon with no significant medical history. He presented with right wrist pain. And the patient reported pain located at the dorsum of the right wrist, distal to the radiocarpal joint, specifically in the radial and central zones. The pain did not radiate to other areas, and the mechanism of the injury was an axial load on the wrist with a clenched fist. The patient has been experiencing pain for weeks and has not had similar pain before. The pain did improve with non-steroidal anti-inflammatory drugs and immobilization. The patient also reports a loss of great strength and worsening pain with activities that require holding objects with the hand or extension of the wrist. The area of tenderness was identified at the radial and central zone of the dorsum of the wrist. The patient exhibited a decrease in the range of motions of the grip, accompanied by pain, particularly during radial deviation and station. During provocative maneuvers, the patient presented a positive Watson test. So for this case, in the differential diagnosis of wrist pain, we consider it neurological, systematic, and mechanical causes. Based on the acute onset of the pain following an axial load, we focused on mechanical causes and ruling out chronic causes of these mechanical causes. After analyzing the signs and symptoms of the patient, our mainly diagnosis was carpal instability. So the patient underwent a magnetic resonance imaging of the wrist without contrast and brought the results to the medical office. We observed the axial plane in T1 and T2 on the MRI. There is a coronal and sagittal plane in T2. The scapholonate distance was 3.2 millimeters. We can observe the presence of liquid in the lunotriquetral joint. Here we can see the measure of the scapholonate distance at the dorsal, mid portion, and volar zones of the articulation of the joint. The scapholonate angle was the lunocapitate angle was 35, and the dorsal translation of scaphoid was 23%. You can see the disruption of the scapholonate ligament. This is the presence of dorsal intercarpal ligament. Here's a lunotriquetral ligament injury. And we can see attenuation of the fibers of the dorsal intercarpal ligament. So the summary of the findings in the MRI was a scapholunate separation, an increased scapholunate angle, an increased lunocapitate angle, an increased dorsal translation of the scaphoid. The scapholunate ligament was extensive and complete lesion of the dorsal and border portion, and we have a presence of liquid at the petrol point. So I would like to ask you.
Thank you, Robin. So here are the questions. Thank you for this great case. Anyone would like to comment? Could you come back to the, please, just Robin, to your questions? The next slide, please. Okay. Shall we ask? Thank you, Robin. Shall we ask someone to discuss the case? For example, one of our fellows can see Lucian, our fellow. One of our fellows.
No, I want to do only a comment. I saw a very precise description of the MRI, but I want to have also to see what my colleagues think about it. I don't really pay so much attention to the MRI test. I really want to go inside the wrist with a scope to scope it and to visualize really the type of instability which I can see with my own eyes. I'm not so into calculating too many angles. I was not good in mathematics in the high school, so I'm not so good in it. But yeah. I'm very concerned more to what I find in the scope. So I will scope the wrist. If the patient has this kind of pain, I will go and scope it.
It is a huge debate. Thank you, Lucian, for this comment. But actually, we trust, especially as Robin presented it, we pay attention to the history of the trauma, and for me, and to the clinical assessments. We have some specific sign of carpal instability here. And I personally ask for X-ray, bilateral plane X-rays, dynamic, and the MRI is for me the minimum for medical legal issues, because if we decide to do the arthroscopy without CT scan, ortho-CT scan, or MRI, it is a problem for medical legal issues, in my opinion, here in France. Does anyone would like to make a comment here for this?
We have Philip Matthew. We have Philip Matthew from the chat.
Yes.
Is telling us would the dynamic fluoroscopy evaluation will be a good option, and I will comment on it. I believe more in this kind of test, a simple fluoroscopy, dynamic fluoroscopy, done by me with the patient, than CT scans or MRI or plain X-ray. But this is only my opinion.
Bulent would like to say something.
For the CT is work well in this position. You can understand all kind of dynamic instability and reductibility of the scaphoid and lunate in this case, in this type of case. And for the CT is very helpful for to understand instability type. Thank you.
So we can
Okay.
You can go on. Yes.
According to Wolf and Carter, carpal instabilities are classified into 6 categories based on their chronicity, constancy, etiology, location, duration, and pattern. So, our patient present with a subacute, static, traumatic, proximal intercarpal disease, rotation, and dissociative carpal instability. we use this classification of Anderson and categorize carpal instability injuries from pre-dynamic injuries with high instability corresponding to a partial ruptus to slack type injuries. Our patient falls into a stage 4 of Anderson's classification, exhibiting a DC deformity characterized by a complete scapholonate injury with secondary changes affecting all stabilizers, secondary stabilizers. In this case, stress radiographies are not required as the deformity is already present. In Garcia-Lia's classification, 6 stages are described, with the first 3 involving lesions without misalignment, and the last 3 involving misalignment. We believe our patient corresponds to stage 4 in Garcia-Lia's classification. However, we believe that subacute lesion could indicate a reparable ligament injury. Here's the wrist arthroscopy, diagnostic arthroscopy.
In the radiocarpal joint, we can appreciate a tear of membranous portion of scapholonate ligament. We identified a step-off in the scapholonate joint and a partial avulsion of the dorsal intercarpal ligament from the scaphoid bone in the midcarpal joint. To assess the integrity of the dorsal intercarpal ligament insertion in the scaphoid, we performed the tug-of-war maneuver. The tear of the scapholonate and lunotriquetral ligaments resulting in the presence of floating lunate sank, or commonly known as the rocking chair sank. Using the camera positioned in the MCR portal, we observed a Geisler 3 type lesion of the lunotriquetral ligament and a Geisler 4 type lesion of the scapholonate ligament.
So our final diagnostic is subacute traumatic carpal instability of the proximal row, dissociative static with reductible malalignment with DC deformity. The scapholonate ligament was classified as a Geisler 4. It was stage 5. Garcia-Lia's stage 4. The lunotriquetral ligament was classified as Geisler 3. And we believe that patient have perilunate injury not displaced. Here's another question for the audience. What surgical procedure would you choose for this patient?
Dr. Ozelic Pulang.
May I make some considerations before passing to the panelists to make the opinion?
Yes. Yes, Gustavo, we hear you. Please.
No, very, very quickly. So, first of all, this is an orthopedic surgeon, a shoulder surgeon. You know, the kind of orthopedic surgeon, not as refined as us hand surgeons. So you can imagine the situation. He already reached the office with the MRI done, with the diagnosis done, wanting to have the operation the next day. But just to clarify why we don't have X-rays, dynamic X-rays, fluoroscopy, dynamic fluoroscopy, and so other options. So as Lucian said, I also agree, we need to make a scope and to define the type of injury and the treatment using the arthroscopy information. So what I need is the MRI report to get approval of the surgery for this kind of private special patient. So this is a consideration about the complementary exams. Regarding the arthroscopy, I would like to address and to highlight some things. It's very interesting. I asked Robin to prepare this case because it's very interesting to us to understand that usually scapholonate injuries are not just scapholonate. We usually have a constellation of different presentations of ligament injuries and patterns. So in this case, we can see very suggested plinged, kind of plinged deformity. We can see that probably he had some kind of injury in the dick that was healed. And this is one thing to highlight. The other thing to highlight is this evaluation, I think was quickly said, but the tug of war sign. It's a sign we are proposing, and I'd like to stress here, is a kind of palpation of the dick in the dorsal aspect of the carpal bones. So we can pull and move the scaphoid or the trachytrum when we do the palpation of the insertions of the dick. So this is very important to us to have to know if the attachments of the DIC, the DIC, the dorsal intercarpal ligament, are normal, are attached to the bones, because this is going to guide us in order to choose the proper or the more proper option for treatment in this case. Just this. So now I would like to hear the other panelists' opinions.
Thank you, Gustavo. I totally agree. For the MRI, we ask at least for an MRI in preoperative time to justify our arthroscopy and for the insurance. And I agree also, we should, when we have a Watson positive and severe instability, we should check the lunotriquetral space systematically, and not to forget this, to check the situations of floating lunates that are not so rare. I totally agree. Thank you, Gustavo. We have other comments.
Hola.
Yes, Dr. Jorquera, René.
Yeah. Hi, Gustavo. Hi, Robin. Very nice case. Congrats, Robin. Excellent presentation. And the case. I think we all agree. We don't have many doubts. This is a static lesion, a static injury of the scapholonate, and I think that I know that Gustavo and his fellow did final. I have seen it in Santiago School. We have something in favor of that is acute and not chronic injury. It's very, very important. When we have a chronic injury, it's very difficult solution in the final. We need a reconstruction of the tear on the scapholonate and lunotriquetral. I think that is when we have a perilunate injuries in the chronic situation, is very, very, very difficult reconstruction. And in this case, when we have a acute injury, I know what is the final treatment of the Gustavo, and I think that in this moment the capsuloplasty is a very good option in the first moment when we have when you reduce of the DC and reduce on the space of the scapholonate, when put of the capsuloplasty in the dorsal part, when you take of the dick is probably a very good option of the treatment. My problem in the polar part of the lunotriquetral injury, I think that is in the second step, put of the capsuloplasty in the polar part and protect of the construction with the ski wires in the several part of the song. And my option when we have a chronic perilunate injury, I think that is the reconstruction of the beak and the scapholunate and the ludotrigetal is the very good treatment.
Thank
Congrats,
you.
Gustavo. I know what is the final treatment.
Robin, please, if you can go on the case.
Okay. Então, the surgical intervention in our case clinic, we conducted a surgical procedure known as dorsal capsuloplasty using monofilament sutures to repair the dorsal intercarpal ligament, scapholunate ligament, and attach it to the dorsal capsule of the wrist at the 3-4 portal. So this is the video of the surgery. This is the tag of war saying that Gustavo Mantovani described. So through the mid-carpal portals, we are conducting a synovectomy, removal of soft tissues, and partial resection of the posterior cortical bone of the scaphoid. A supersuture was placed inside a hypodermic needle, and the needle was inserted 2 centimeters radial and 1 centimeter distal to MCR portal, targeting the mid-carpal joint. So the suture was retrieved through the carpal joint portal using the same needle without removing it from the skin. We inserted into mid-carpal joint 0.5 centimeters more ulnar to the previously entered point. This second suture was also retrieved from the MCR portal. And the same procedure was performed for the dorsal intercarpal ligament insertion near to the truncatum bone. The entry point was over lunoemate joint, and posteriorly, it was shifted 0.5 centimeters more radial without removing the needle from the skin. It is the second insertion of the needle and the retrieve of this suture through the MCU portal. So at the final, 2 supersuture loops were obtained anchored to dorsal intercarpal ligament near to its insertion on the scaphoid and 3 petrum bones. Next, a new monofilament suture was inserted through the 3-4 portal, passing through the scapholunate ligament and directed forward at the mid-carpal joint. Here's a loop of the monofilament in the mid-carpal joint. So the previously anchored suture in the dorsal intercarpal ligament of the radial side was retrieved using this monofilament suture. And the same procedure was repeated for the ulnar side. Here we pass the suture through the scapholunate ligament, retrieve this monofilament at the mid-carpal joint, retrieve that monofilament using our MCU portal, and we use this monofilament to retrieve the supercharge from the 3-4 portal. This is the final configuration of the technique. By pulling the two sutures, the reduction of a scaphoid bone surface with the lunate surface could be observed. And we'll maintain a neutral extension. We gently pull the suture to thick it and create a knot. It's important to ensure that there are no sutures around the tendons or nerves. So the postoperative post-surgical care or patient 5 weeks of postoperative. We relies on radiological assessment of the patient, and here we can see the scapholonate distance in the right side is 1.5 millimeters and 0.5 millimeters in the left side. The gilula lines are symmetric in the right side. Here we can see a clinching fist position and to evaluate to produce an axial load in the carpal bones and to evaluate a separation of the scapholonate space, and we think there are no difference. The angles in the lateral views, the scapholonate is 45 for the right side and 43 for the left side, and the lunocapitate angles was 11 to the 11 graus to the right side and 10 graus to left side. There is a video of 5 weeks postoperative. And I have to remind the patient was immobilized and the flexion of the wrist was restricted. And we can see the scars for the mid-carpal and radiocarpal portals. So thank you for everyone. This was the clinical case.
Alam, we have a question from the chat. Can you hear me?
Yes, perfect.
Yes, we hear you. Sorry.
Paula Ramirez asks Gustavo and Robin, do you use a key wire to correct the dizzy before doing the capsuloplasty? Or
No,
does the capsuloplasty corrects it by itself?
No, we didn't use key wires after the supercapsuloplasty. We believe that the biomechanics that provides supercapsuloplasty with the anchored sutures in the dorsal intercarpal ligament, it can reduce the lunotriquetral angulation and the lunotriquetral joint and the scapholonate joint. We didn't use key wires after the supercapsuloplasty.
Okay, I'm doing your
question.
my compliment, Robin. It was a very beautiful presentation by yourself.
The point is that important point to stress out that we indicate the capsuloplasty, the supercapsuloplasty, we restrict it to reducible cases. So it's very important. So it's if it is some stiffness in the wrist, very chronic, and if in the arthroscopy you cannot reduce naturally with closed maneuvers and with the palpation of the scaphoid, if you see the scaphoid not move and the gap is not reducible, we don't believe soft tissue simple procedure like the supercapsuloplasty is able to maintain and have a good result. So we need to move forward for another more complex reconstruction. So in this case, and when we indicate the supercapsuloplasty, reducible situations, we believe it's not necessary to have Chi wires in the surgery for reduction and after the surgery. So the suture is strong enough to maintain the good alignment between the bones.
Gustavo, thank you for your comment. I have a question for you, Gustavo, and for Robin. In the chronic cases, do you think we can, after a debridement, a very extensive debridement of the soft tissues, do you think we can go back to a kind of refreshed lesions and use anyway this kind of techniques, your techniques or the Matulin, the modified Matulin as we use it here, or a technique that I use, which is very close to yours. Do you think we can, in the chronic cases, and until when can we use this kind of technique, Gustavo?
Definitely, it's a good question, because this is a very important thing, which I think we can classify around reducible situation and chronic situation. But in arthroscopy, you definitely can change this. You can change both chronicity and both reducibility. Mm. So if you scare, and we do use this technique for chronic cases, for us, the major aspect is the quality of the soft tissues you have to perform this technique. So if you have a chronic case, and even in this case, we do make a scarring in the bone, in the dorsal aspect of the scaphoid and the lunate, the areas where the ligaments were detached. We do make a bone scarring to increase the fibrous scar tissue and adherence of the capsuloplasty. And there is the reducibility.
Sorry, yeah, Gustavo.
Also, the reducibility eventually can be changed. We had some cases also with a lot of scar tissue in between the scapholunate, and when you make a long and careful cleaning, arthrolysis, we also can change this situation. So it's also to consider.
Please, Gustavo, my last question after I will let the all panelists to ask their question. Where do you do, where is the most important area where we should do this bone scarring, in your opinion? In the scapholunate space, in the dorsal aspect, close to the DCSS? Is there a specific for you area where we should refresh those tears, chronic tears?
On the dorsal of scapholunate, in the adjacent part of the proximal pole of the scaphoid, and in the lunate, if you have the detachment on the lunate. For instance, in this case, we have a perfect attachment of the capsule and the scapholunate ligament in the lunate. So we don't have the lunate exposed in this case, so we just make the scarring in the scaphoid. So every part of the bone you find a bowed part of the bone, I believe you can, with the shaver, the bone shaver, you can make some bone scarring in the dorsal.
Thank you. René, you would like to, thank you, Gustavo. René would like to make a comment.
Abderrahman and Boulen is
Abderrahman
to me.
Or so, René and after Abderrahman, it doesn't make any difference. Thank you. Sorry.
No problem. No problem. Impressive, Gustavo, and congrats, Robin. And I saw the technique in the Santiago Ruiz course 1 month ago, and I think that is very, very, very good option, and stronger capsuloplasty would permit of the the stabilization of the scapholonate and DCSS is very, very good. My thought is we are working together, Martin and Gustavo, in the currently of the DIC of the scapholonate. I think that is, my thought is that the DIC is the most important part of all. Other work with capsuloplasty and reconstruction is aimed at that. I think that the DIC is the most important ligament in the stabilization of the carpal injuries. The capsuloplasty in the DIC, the capsuloplasty, the stubborn capsuloplasty and reconstruction on the prelunate injuries. I think this is the very, very, very good treatment. Impressive, Gustavo. Congrats. Huh?
After we have, thank you, René. We have a quick comment. And after we have Gustavo Gomez Bülent. Abdelrahman, please.
Hello.
Yes, we hear you.
Yes, thank you very much for your presentation. Very good demonstration of the technique. My question is, if we are the difference between the supercapsuloplasty and the regular capsuloplasty, to what I understand, is that we are taking two parts of the capsule that are separate from each other instead of one in our usual capsuloplasty. But why not just do another procedure, including the capsule and through the lunotriquetral joint? In your case, the lunotriquetral ligament was also injured at the same time in the presentation. Why not just also take that and make two separate capsuloplasties? Why take two capsule areas and combine them through the scapholonate interval instead of two places?
It's a very good question. Thank you. The point is the conventional capsuloplasties we use to perform, the big difference about the supercapsuloplasty we just shown is the distance between the anchoring points or the distance between the tissues you want to short. So the traditional capsuloplasty is a little distance around the scapholonate joint that you make some shortening, just like the Matulin technique and the variations of Matulin technique. The difference for this capsuloplasty, and that's why the mechanical effect is increased, is that you get a more long distance between the two anchoring points. And you have a stronger tissue to deal with. This is the very strong ligament, the DIC ligament. So in this way, you have much more ability and much more effect for reducing and to bring those bones together. And also the benefit is that the DIC ligament is also attached to the trachytrum and also plays the same role of stabilization in the LT joint. So with just one procedure, you can treat the both joints. So just as in this case. So this is why I also asked Robin to present this case, because it's a good example that the capsuloplasty can treat both scapholonate and both lunotriquetral joint. You don't need to make two separate procedures for each one. So with one shortening of the DIC, you can treat the perilunate non-dislocated situation like this one.
Thank you.
We have Bülent for the last comment after. We need to move after the...
Thank you, Gustavo, for your good case. I want to sure that you always think that the dorsal capsule and the classification which we have now for the carpal instability isn't enough. We have to add something about the dorsal and volar capsule detachment. It's very important, and somebody has to do a new classification with dorsal capsular issue. And you know, I have a new technique with suture button, and in this technique you could fix the scapholonate and lunotriquetral joint in the same time, and you can fix, you can put internal fixation with a suture button, and you can correct the DC deformity and scaphoid flexion in the same time. It's possible to use this kind of operations. And my question is it possible flexion contracture with this technique? It is very tight, and for the dorsal side, the patient has got some difficulty to flex the wrist after the operation. Do you have any problem after your case about the wrist flexion?
Yes, thank you for the question. I know your technique. I think it's a very interesting and very smart technique, and I consider your technique very interesting for the more severe cases. So I still do not use it, but when I have a case with more stiffness or more difficult to reduce the scapholonate, I probably will consider your technique. I think some kind of internal brace or internal fixation should be required, just like a Russell or just like your technique. But regarding the flexion, you are right. The drawback of this capsuloplasty is stronger, and of course it restricts more the flexion of the wrist, especially at the beginning, because it stands like 6 weeks with immobilization. So there is timing for gain flexion around 3 months, and we still have in long term some small lack of final flexion. So we have in our patients, more long follow-up patients, we have a lack of around 20% of final flexion. But definitely this is not a functional problem for them, and they're very satisfied with the result.
Thank you, Gustavo. That is why I think in this kind of supercapsuloplasty or DIC plicature or modified technique of Matuna, we should not indicate those strong dorsal suture in all the EOS stages, just in the advanced stages, because we have this issue of the loss of flexions, and it is 15 to 20 degrees. I totally agree. So I think Paola, thank you, Gustavo. I think Paola Ramirez is trying to speak since. Hello, Paola. You can ask your question, please, and after you.
Yes, hello. Yeah, I can't raise my hand because I don't have the button on my screen.
Sorry.
Well, nice guys, nice case, Gustavo. I just have a real question. So, your case, we have like a scapholonate ligament lesion, EOS 4 type of lesion. You decided capsuloplasty, which is like dorsal. And in this case, what do you do in the ligament volar part? Do you do something? Do you do nothing since it doesn't have like a rocking chair sign? So that was my question.
Okay, this is a big controversy if it's necessary or not to address the volar part of the scapholonate in those cases. So this is a discussion around the defenders of the box concept, the 360 reconstructions, and so on. In our experience, we used to try the less. The less is more for us. So we try, we check in the arthroscopy the effect of the capsuloplasty. So when we simulate the final suture, we test the stability. And in our opinion, we usually have a good stabilization of both dorsal and volar part of the scaphoid. So we don't believe it's so important to perform a secondary procedure for the volar part. The same for the lunotriquetral joint. In this case, after testing the final suture, we find good stability of the LT joint, so we do not decide to make any kind of other procedure in the volar aspect of the joint. So we used to defend that probably the volar injury is not so relevant in these type of situations. Maybe for EWAS stage 3B, I'm not sure if the right letter, but when you have isolated volar injury, of course, you must address with some procedure for the volar reconstruction. But for those stage 4s, we test the final result in the arthroscopy. Still, until now, we do not have a case that I found a big instability only in the volar part that makes me think about doing a secondary procedure.
Thank you, Gustavo. Thank you, Gustavo and Robin, for this very nice case. Congratulations. And we need to move to the next case from Istanbul with Erkan Sabri and Mamrat. This is a nice case of TFCC foveal ligamentoplasty. Erkan, can you hear us? Can you hear us and share your screen, please?
Okay. Do you hear me?
Yes, we can hear you, but for the moment, and we can see your screen. It's perfect. Thank you.
Okay. Hi, hello everyone. The presentation is prepared by other visiting fellow, Maram Samrat, but he was going to his country now, so I will make the presentation myself. I am practicing as a hand surgeon, and now I am visiting fellow at the Istanbul International Risk Center. I will present the case to whom we applied extensor carpulnaris half-split turnaround ligamentoplasty. If you look at the history and physical examination, 49 years old female patient, history of injury is fall onto an outstretched hand, and she was tenderness, swelling, and deformity on his wrist, on her wrist. When we look at the radiographs, we see some radial shortening and also a loss of radial inclination and loss of volar tilt. As we think about Lafontaine criteria, as we take account that the surgery, we planned a surgical treatment. There are some treatment options we can think about. Also, conservative treatment may somebody think about this, but we choose volar plating of the distal radius. After fixation, do you any comment about what next step? Any comment about this?
Do we have someone who would like to comment this first step of the osteocentesis? I can see Francesca or someone else, please.
I would have done the same thing, like just a simple plating. I don't know if one of the screws is a bit like out though, or maybe it's just the radiographical projection.
Yeah, it may be a bit longer screw, the most proximal part.
I think we don't have enough information now to answer this question. Yeah, maybe we need some more information about the clinical assessment intraoperatively, no?
Yeah, next step is the clinical assessment. Intraoperatively, we do Ballotman test. You see the subluxation of the ulna. You know it is a subjective clinical test, so we compared with the contralateral side intraoperatively. So there is not such a laxity in the other wrist. So we So we plan to do something about the distal radial ulnar joint. Also, we performed intraoperatively a wrist arthroscopy. While you using standard midcarpal standards 3, 4, and 6R portals, we do a radiocarpal arthroscopy, and you see here the hook test is positive. Also, here is trampoline test. We do here trampoline test, and after we do hook test. Please give attention. TFCC touched the lunate bone. So we hook test with side is positive in this patient. Also, we applied midcarpal arthroscopy, and we see the SL and LT ligaments as intact. Here the SL and LT ligaments. Next step, which treatment type you prefer? Any comments about the treatment types?
Do we have a quick comment in the panelist, maybe? You can see Francesca, she wants to answer.
I guess at this point I would do a foveal repair, either anchor or ulnar tunnel. Me personally, I'm more comfortable with the ulnar tunnel technique, so I would do treatment number 5.
Okay, so treatment for Francesca. Erkan, could you please tell us what you choose in this case?
In this type, we have developed a new technique developed by Mr. Bülent, pardon. You see.
Can you comment a little the case? We can see that
we have
the technique. Yes.
We do an approximately 6 cm longitudinal skull incision is made on the dorsal side from this level, and dorsal sensory branch of the ulnar nerve is identified and protected. ACU distal tendon sheet is incised here. You see the dorsal sensory branch of the ulnar nerve and we protect it. And ECU distal tendon sheet is incised, and partial ECU tendon graft is harvested. ECU graft is taken out from the extensor retinaculum. You see here, extensor retinaculum. The graft is unsutured, and the graft is taken dorsally and proximally subcutaneously through the incision made for the 6R portal. We put the tendon to 6R portal subcutaneously. After getting tendon to 6R portal, the graft is taken through a volar DRUJ portal without any incision and taken over fovea, volar to dorsal side around the ulnar styloid process and above the central ulnar ligaments with the help of mosquito clamp. ECU graft is taken under the extensor retiniculum and short insert with the pulver-tapped wave technique. You see the postoperative development test here. There is no subluxation. What we do postoperatively in standard cases and foveal repairs, there is need for between 6 and 8 weeks immobilization. But in our technique, there is 3 weeks immobilization is enough for the healing. And ECU tendon also this ECU tendon acts as a dynamic and static stabilizer effect. The ECU tendon slip is rotated around the ulnar styloid and stored back onto insert, which not only provides direct stability on the distal ulnar joint, but also indirectly increases the stabilization by stretching the remaining soft tissue stabilizers, both proximal and both dorsal and volar radioulnar ligaments. We applied this surgery technique for acute and subacute cases, not for chronic cases. Up to 4 months injury, we got successful results. If you look at the advantages of this technique, it's straightforward and it had a shorter operation time. We do not need any bone tunneling, so we avoid complications about related to bone tunnels, such as fracture, expansion of the tunnel, and loosening. Also, it excludes potential problems that open TFCC repair includes. As you know, open TFCC repair disrupt structures to dorsal ulnar carpal capsule and extensor retiniculum, and potentially the distal radioulnar ligaments. And we no need for fluoroscopy, so prevention of additional dose of radiation is possible. There is no need for any implant fixation, which avoids also implant-related complications. If you look at the possible complication of this technique, maybe dorsal sensory branch of the ulnar nerve may be injured. Also, rupture of the tendon graft may be occurred, but we don't have any kind of complication yet. Half thickness of ECU tendon is appropriate to perform this technique. Also, for chronic cases, Nakamura used the ECU tendon as a reconstruction procedure. Infection and recurrent instability could be other possible complication of this procedure. But in our case series, we do not have that kind of complications yet. Any comment about the technique?
Thank you, Erkan. Could you stop sharing your screen, please? Okay, I think we have many questions from. It is the end, Erkan?
Yes, yes.
Yes. Could you stop sharing your screen, please, so we can be all together? And I think we have many questions. There is a kind of many questions for the indication. I think Bülent will try to help us for the indications everyone is asking. I think why have you indicated ligamentoplasty in this case instead of simple repair? Maybe Francesca, Ruchi, and Gustavo, someone would like to ask the question.
May I say something?
Yes, sir.
We add something more. I think the Erkan missed the arthroscopic view. We have to add something more. But in this case, we have an urgent situation, and we haven't got any possible other options. We haven't got any encore, we haven't got any cannulated drill, and we have to do more. And we have to fix the foveal site, and we thought that we could do something with ECU, and we did several cases like that when we have got some possible difficulty, we could do this technique. If you haven't got anything in your hand, you can do it easily, and you don't need any other tools and other anchor, whatever you need. And the techniques gives us why we need ligamentoplasty. We have to do something about foveal reinsertion. With this technique, the ECU compress the fovea through the over the TFCC, and in the same time the ulnar and dorsal, volar and dorsal radioulnar ligaments stretching, and the ECU gives a dynamic stability in the same time, and you can generally, if you sure that your pulvar tuft tendinous reconstruction, you don't need to restrict the wrist forearm rotation. It is the most important thing. If you have got a good pulvar tuft tenodesis, you don't need to restrict and give the early movement to gain range of motion. It is very important.
Thank you, Bülent. So if I understand, we don't touch to the radioulnar ligaments. So we don't, in your technique, we don't cut the bridge. We don't burn any bridge, sorry, to do foveal reinsertion in the future. That is the, if I can understand, that is your philosophy for this technique in the acute case.
Yes, generally in acute case.
Yes, and you have, how many cases you have like this?
6 or 7.
Okay. Okay,
and,
so
may I ask Erkan, the arthroscopic tendon graft passing in the TFCC, if it's possible, Erkan will show it. The tendon come over the TFCC and it compress it. It could be shown in the arthroscopic view, but I think
we saw it. We saw it. So
Erkan could show it.
The next slide, I think, Erkan.
In this slide, I think. Yes, this view.
So we can see the stretching of the radioulnar ligaments, the TFCC. Okay.
And now you see the tendon structure. Yes, tendon pass over the TFCC, and TFCC is coming over the foveal side.
Thank you, Erkan. Thank you. So it's very interesting technique, Bülent. And I think it is a good transition because I know, thank you, Bülent, thank you, Erkan, for this nice case. I think everyone is impatient because the discussion are a bit long, but we have a video that could be a transition of this technique. And if you allow us to share the video of Gustavo, which is and we are sorry for the delay. So I think Sergio Autos from Sao Paulo, could you share very quickly your video, please, so we can conclude this discussion, because it's we are in a very similar situation.
Hello, can you hear me?
Hello, Sergio. Yes, we can hear you, Sergio. Hello.
I will pass my video very fast for the time.
Please. Yes, please. Thank you.
you can see my screen.
Perfectly, thank you.
It's a video format. I'm Sergio. I'm a fellow on Sao Paulo Hand Center with Dr. Gustavo Mantovani. I will introduce to you the TFCC foveal insertion around styloid. This is a technique by Gustavo Mantovani. And let's go. We have an advantage of the around styloid. It's a low-cost technique. It's fast, reproducible, and we can attach the TFCC on the footprint of the distal ulna. Here we can sequence of animation. The principal steps is one needle on each side of the styloid to suture passes. We use a non-absorbable suture like at-bond or fiber wire, and the fixation of the distal ulna can be doing with a transosseous suture or an anchor. This is a sequence of the position of the needles and the passage of the sutures. Here we can see the tract of the suture, the strong suture, and here there is an image of the lateral view of the distal ulna when we choose the transosseous suture. Our patient, there is 43 years, it's a fall of the wrist extension, a ulnar pain, and we can go to the surgeon. A Boltzmann test positive indicate the distal ulnar instability. A 3-4 portal view, we can see a trampoline test. In this case, in this patient, we have a trampoline test negative, but we have a RUC test positive, which characterize on the ATSE classification, class 3, with only proximal avulsion of the TFCC. We can see a good view with the TFCC touching on the carpal bones, which characterize the proximal lesion of the TFCC and avulsion on the foveal insertion. Here, next, we can see the ghost sign we pass the probe below the TFCC. We can see the foveal avulsion seen by the 3-4 portal. And we pass to the DRUJ arthroscopy, needle DRUJ D, this portal identification with a needle. And we use the direct foveal portal to the instrumentation. We can see the identification, a mini open access, subcutaneous dissection with caution with the dorsal branch of the ulnar nerve, and we use the DF instrumentation to the DRUJ arthroscopy. We see some kind of synovites using a mini shaver to synovectomy to see the foveal part of the distal ulna, and we use a mini burr to foveal debridement of the DF portal. And here is an important step. We can see a foveal footprint debridement aspect. We believe this is a large area on the foveal to the attachment of the TFCC. We're doing a mini ulnar access. The reference is the base of the styloid and the ulnar neck. The subcutaneous dissection. And this is not our reference to pass our needles to make the pass. It's an important step, the UCU identification, the stersor carpal ulnaris. We do a mini open of the ulnar sheath and to exposing the floor of the ECU tendon. It's a reference to the passage of the needle. Here the passage of the volar needle with the view of the 3-4 portal view. We can see the needle passing to the volar aspect of the TFCC And this volar, this needle contains mononylon suture with a loop, which we can use to make the passage of the suture. On the 6R portal, we pull out this mononylon suture to the exterior phase of the surgery. In the specific case, we use an anchor drill to make it anchor to make the fixation, the anchor drill, anchor fixation, and this fiber wire suture we use to make the fixation with the dorsal needle. Here we use a dorsal needle with the fiber wire and pass on the ECU floor, directing through the dorsal portion of the TFCC with caution to do not damage the carpal bones cartilage and make a good position of the needle on the dorsal part of the TFCC with this strong non-absorbable suture. In this case, it's the fiber wire of the anchor, but we can use a simple etch bond. The passage with the fiber, and like the other needle, like the mononylon, we use a mosquito from the 6R portal to pull out the suture. On the left, we can see the sternal phase of the surgery. We're doing a simple passage. I will edit the video to pass this start. Come back here, and we use the mononylon loop to make the passage to the fiber wire, the dorsal to the volar aspect of the TFCC. It's the name. It's because the name of the technique is around styloid. And here is important view of the surgery. We have the styloid on the center and the fiber passing on the dorsal and the volar aspect of this TFCC and reattaching on the foveal portion of the distal ulna. We have the final aspect, a good insertion and fixation of the TFCC. The root tests now are negative, and a good stabilization immediately seen in the intra-op part of the surgery. Next, we can use a monster orthosis to block the pronal supination movement and permit the flexion extension of the elbow. And 2 months post-op, the patient with a good arc of the motion of the wrist and a good stabilization of the distal ulna, and she had no pain. Okay, thanks.
Thank you so much for this great presentation. I will let maybe Gustavo or you give a last comment for your technique. Maybe Gustavo Mantovani and Bulent as well, because
I think we lost Gustavo.
We lost Gustavo Mantovani?
No, he's back.
Okay.
And it is the same idea to make a compression over the TFCC, and TFCC compressed over the foveal, and in the same time you get the dynamic stability and with dorsal and volar ligament of the TFCC. And AGU gives more. It's all you fix the ECU and it fix all degrees of the dynamic stabilization of the wrist. It's add a little more than this technique, but it is the same idea. Thank you for your good presentation.
Thank you, Bülent. Gustavo Mantovani, a last comment after we close the symposium, please.
Just a quick comment. This technique, in fact, I use it around 20 years from now for treating the acute TFCC instabilities in distal radius. I used to make it open technique with this small approach. So it's a very reproducible and easy way to manage these lesions. If you enter with your suture in the floor of the ECU, in the dorsal aspect, and if you left in the volar aspect of the styloid, and you have this cerclage type suture in the neck of the ulna, you will always fix the TFCC in the right position, even if you're not seeing in the arthroscopy. So when we do arthroscopically, it's a more refined way to do the same we used to make before, when we can see where the sutures are passing. The benefit of this is that you don't need a drill, you don't need to make the bone tunnels, you don't need the fluoroscope, and you don't need even an anchor. We use the anchor in this case to make it easier and faster, but you can do a transosseous suture in the ulna neck and make a kind of cerclage suture. So that's our contribution for as another option for the TFCC reattachments.
Thank you so much, Gustavo. Thank you, Sergio. I think we need now to end this long symposium for today. I'd like to thank all the fellows for the great presentations that they prepared. Congratulations. The next webinar is scheduled in 3 weeks, in June 24, on Saturday, the same time. You will, for the attendees, you will find the link to register on the LinkedIn and the Instagram accounts. So once again, thank you, everyone. Have a nice day or a nice evening, and see you very soon, everyone. Thank you.
Thank you, Lan.
Goodbye.
Thank you, everyone. Bye-bye. Thank you.